This is a recorded lecture titled Critical Congenital Heart Lesions. A quick disclaimer, the original slides were prepared by Dr. Martin Wong, who is a consultant pediatric cardiologist from Hospital Umum Sarawak. Let's start with congenital heart disease as a whole. The incidence of congenital heart disease is approximately 1% of all live births, of which 1/4 are considered critical lesions. I will explain what are critical lesions. These remain a leading cause of infant mortality in the developed countries. In the underdeveloped countries, on the other hand, the leading causes are such as infection, prematurity, and so on. However, there has been tremendous improvement in outcomes over the past 2 decades, mainly because of early diagnosis, early intervention, and so on. And therefore, it's very important for us to detect and be able to detect, especially critical lesions, as early as possible. This is the outline of the lecture. So we will go through several case studies and we will explain what are the critical congenital heart lesions, what are the caveats, what are the catch of us missing one, okay, and how not to miss one, and I will talk briefly on the management. Let's start off by discussing about the first case. This is a term baby that was delivered in a district hospital, a good weight, term, good APGAR score. The baby was rather active and feeding well. On routine newborn examination, the baby essentially normal. So the baby was pink, there was no murmur, there was no signs of respiratory distress, the baby was well and was sent home after 24 hours. 2 weeks later, the baby was brought to the accident and emergency department. Very side note, saturation at that time was only 20 to 30%. Of course, the team resuscitated immediately and attempted to transfer to the state hospital by ambulance. That was in Sarawak, so understandably the district hospital, the transfer may take hours. And this was the chest radiograph taken in the district hospital. Notice the lung field that is rather black, or we call it oligemic. So in the state hospital, an urgent bedside echocardiography was done, and it showed a pulmonary atresia without any septal defect, okay, and there was no PDA, okay. Atresia simply means a complete obstruction. So there was an attempt to start this particular medication called prostaglandin. I'll explain towards the end of the slide. However, it was too late and the baby died within 2 hours. So think about what went wrong and how could it be prevented. The second case was born in the state hospital itself. Same story, term, good weight, good APGAR, normal examination, and was planned to discharge in the same afternoon. I presume it's less than 24 hours. However, just before the discharge, the mother, who is quite alert, noted that baby's respiration or breathing doesn't seem to be normal. And the baby was immediately referred to the pediatric team. The baby was noted to be moated, dusky in color. The cry was weak and grunting, and there was recessions. And when we examined the peripheral pulses, and the perfusion was very poor, and again there was no cardiac murmur. An arterial blood gas was done, as you can see, severely acidotic and due to metabolic acidosis predominantly. As usual, the baby was immediately resuscitated with multiple fluid boluses. Inotropes were started, in this case dopamine and dobutamine. Of course, we will need to suspect sepsis being the cause, and antibiotic was also started. However, the baby did not improve with the first line of care. A congenital heart disease was suspected, and echocardiogram was done on the next day. It shows severe coarctation of aorta with very little PDA flow. Again, prostaglandin E was started, and unfortunately the baby still succumbed on day 3. Again, think about what went wrong, how could it be prevented. This is the last case, case number 3. This is a rather, towards the end of the neonatal period, day 27. This baby seems to be rather comfortable, quotation, okay, just that the baby appear to be blue. The same story during the perinatal period, term, good weight, good upguard, discharged well. And when the baby was sent to the to the hospital, the saturation was noted to be only 70%, but strangely there was no tachypnea or signs of distress, and again there was no heart murmur. Pay attention to the shape of the heart, and again the oligemic lung feel. Congenital heart disease was suspected, a cyanotic congenital heart disease, and echocardiography was done, which showed a transposition of great arteries. There was no VSD, and the PDA has closed. Okay, a procedure called balloon atrial septotomy was done. Saturation improved from 70% to low 90%, and being a TGA, urgent surgery need to be done, and the child was transferred to IJN. Unfortunately, because this particular procedure called arterial switch operation, which typically had to be done within the first 2 weeks, was done quite late. In this case, after 1 month, the baby coped quite poorly post-operatively and succumbed after 5 days after operation. And I think you get a good picture of what are the common features of all these three cases. Again, you don't often get a case whereby there would be a very eventful perinatal period. All seems to be rather so-called low risk, and all of them did pass the routine newborn examination that include your examination of the respiratory and cardiovascular system, no murmur. Okay, and these lesions that I have mentioned, those are highly treatable. Yeah, those are the conditions that are compatible with life. So in this case, we are not talking about conditions whereby they are incompatible with life. Okay, those conditions we give them a term as lethal congenital malformation. But in this case, such as for example, transposition of great arteries, those are highly treatable. Okay, however, the outcomes became poor because of late presentation and because the baby has already decompensated. So what are the neonatal critical heart lesions? What are the types of critical neonatal heart lesions? So number one, I think we have to pay attention that they do present, may not, the majority of them do not present immediately after birth, but they do present later on in life, and importantly, those are the highly treatable lesions. Before we go on to explain further on critical congenital heart lesions, so it's important for us to understand the fetal to adult circulation transition. This is a very important slide, and I need all of you to go back and study further. Suffice to say, in utero, because the pulmonary vascular resistance is very high, because there was little pulmonary blood flow, because most of the exchange of nutrition and gases take place in the placenta, so the pulmonary vascular system is all in a very high resistance state. As soon as the baby is born, this high resistance state has to drop rather dramatically and rather rapidly. Due to this resistance drop, there will be a dramatic increase in the pulmonary blood flow, and that will lead to oxygenation being take place now. Instead of in the placenta, it will take place in the lung as the baby take in the first breath. Okay, so PFO closes, and with the increased oxygen in the blood, the PDA would also slowly constrict and subsequently close, usually by first week of life. So these lesions, they tend to do well because, remember, the pulmonary blood flow is not essential in utero. Okay, and however, because then the pulmonary blood flow need to increase after being born, and therefore typically the lesions tolerate very poorly with the transition of circulation from fetal to adult. So by and large, there are 4 types of critical congenital heart lesions: the duct-dependent pulmonary circulation, duct-dependent systemic circulation, paracirculations, and lastly, obstructed pulmonary venous drainage. I will focus more on the first three types. The first type being duct-dependent pulmonary circulation. Duct here means ductus arteriosus. In this particular type of critical congenital heart disease, the right ventricular outflow tract is obstructed. The right ventricular outflow tract means the tract that delivers blood from the right side of the heart to the pulmonary system. So in this case, it could be a pulmonary artery, it could be through the tricuspid valve or the pulmonary valve. Oh, the examples are shown in the slide. Obviously, because of the lack of blood flow into the pulmonary circulation, there has to be another path that allows some form of mixing and bypassing the obstruction. In this case, the ductus arteriosus therefore becomes important for this to occur. So in this case, because there's little blood into the pulmonary system, the baby tends to be cyanosed. In the early state, the baby may or may not appear to be in distress. Okay, they do sometimes appear to be rather so-called comfortable. Again, there's no heart murmur because in this case, there is no turbulent blood flow through any defects or any valvular defects and so on. So if we are to take a look at the chest X-ray, pay attention again to the oligemic lung field. The second type of critical congenital heart lesions are what we call the duct-dependent systemic circulation. Now in this case, rather than the right ventricular outflow tract, it is the left ventricular outflow tract that is obstructed. Of course, the left ventricular outflow tract I'm referring to, it could be the aortic valve or it could be the aorta itself, either the arch of the aorta or the early part of the descending aorta that is obstructed. So examples therefore here include severe coarctation, interrupted aortic arch, and critical aortic valve stenosis. Again, because there's very little blood that passes through the outflow, the left-sided outflow tract, and therefore the baby do present with a clinical presentation of shock because there's no blood flow in the systemic circulation or very little blood flow in the systemic circulation. The baby would present with absence or poor peripheral pulses, shock again, poor perfusion, blood pressure will be low. Of course, because of the lack of blood to the different organs, that would be renal shutdown. Okay, there will be metabolic acidosis and baby would collapse. So again, if you pay attention, these are also the common symptoms and signs in a child with, take for example, a severe sepsis, okay, or IEM. IEM stands for inborn error of metabolism. The third type of critical congenital heart lesions are the parallel circulation. In this case, of course, a good example would be transposition of great arteries. So in this case, the right ventricle, instead of draining into the pulmonary artery, it drains into the aorta. On the other hand, left ventricle, instead of draining into the aorta, it drains into the pulmonary artery. So there exists two parallel circulations. So therefore, you can imagine survival will be impossible without any mixing. So the mixing can occur in the interventricular septum in the form of ventricular septal defect, in between the atrium that we need to create in the form of either PFO or through a procedure called balloon atrial septotomy, or of course through the patent ductus arteriosus. Again, that would present to be cyanosed because again there's the blood will be rather low in oxygen because of the parallel circulation. However, there is either very little or no respiratory distress, no heart murmur. Again, look at the chest X-ray. The appearance of the heart shape of it on site may not be always apparent in all X-rays, but they can even appear to be normal. The last type of critical congenital heart lesions are obstructed, obstructed pulmonary venous drainage. So in this case, the pulmonary veins, instead of draining into the left atrium, they drain into the right-sided structures, for example, the superior vena cava or the inferior vena cava, and so on. This leads to a severe pulmonary venous congestion. Remember, pulmonary veins comes from take oxygenated blood from the lung. So, and it drains back into the right-sided heart structure, and therefore it goes back to the lung. So it leads to severe pulmonary venous congestion and pulmonary edema. So the abnormal drainage along the path can also be obstructed. So this is termed obstructed TAPVD, or total anonymous pulmonary venous drainage. In this particular example of critical heart disease, they do present very early, almost immediately after birth, unlike the examples that I gave earlier. So, and they do present with early and severe respiratory distress, again, unlike the few lesions that I mentioned earlier. They have marked cyanosis, and if you take a look at the X-ray inside oligemic lung field, the lung field will be very congested, okay? Almost appear like a ground glass appearance, like as though this is a hyaline membrane disease. Pay attention to the X-ray attached. And these can, on the other hand, mimic a lung parenchyma disease. I will now go on to discuss about what is the catch, what are the caveats, okay, in critical congenital heart lesions. So the majority of these lesions are asymptomatic, especially within the first 24 hours or even the first few days of life, and this is because the ductus arteriosus still remain open. Of course, the exception would be obstructed TAPVD, as I mentioned earlier. Many of them do not have an audible heart murmur, or a majority of them also do not have respiratory distress as a sign, and then they do present rather abruptly. And in most of the government hospital, public hospital, newborn examinations are performed by junior doctors, typically a house officer in training, and therefore they may miss certain physical signs even if they present. Okay, and again, in most public hospital, there's a policy of early discharge because of bed issues. The caveat number 2 is many of these conditions also can present very similarly to other more common conditions, such as parenchymal lung disease, for example, hyaline membrane disease, pneumonia, and so on. Okay, and therefore it could be missed. There's another condition called persistent pulmonary hypertension of newborn, or PPHN, that can also mimic a critical congenital heart disease. And as I mentioned, severe sepsis and IEMs that can mimic a duct-dependent systemic circulation obstruction. With this knowledge in mind, now we'll talk about how not to miss one. What are the ways that we can make an early diagnosis? We start off with prenatal diagnosis. That is, of course, the ideal situation. We make a diagnosis even before the baby is born, okay, when the baby is still in utero. If we fail to do that, then we must aim to make a diagnosis of critical congenital heart disease before they become symptomatic. Okay, and lastly, after they develop symptoms, especially those that mimic other conditions, then how do we not miss one, and also making a diagnosis even after they start to develop symptoms. So prenatal diagnosis is typically done during the detailed scan, usually between 18 to 22 weeks. As you can see, sensitivity is not very high. Of course, this is quite a dated data here. So I'm sure the result may be better now. So it can be done by basically doing an ultrasound scan, a detailed ultrasound scan, and to demonstrate those heart lesions. Now in Malaysia, I think mostly this is still done to pregnant women who are at risk, or those with identifiable risk, such as, for example, family history of congenital heart disease, if there are other non-cardiac malformations, for example, single kidney or and so on, or if there is a maternal diabetes, or is the mother taking any drugs that could be teratogenic. Well, that do not and that cannot detect all the critical congenital heart disease, obviously, because of these limitations. Number one, there may be limited number of trained sonographers in our country, and it's very operator dependent. So a less experienced sonographer or obstetrician may not be able to pick up, especially the more complex congenital heart disease. Well, since many of them will still be missed at the point of delivery, and therefore it's important for us to make a diagnosis before they become symptomatic. Okay, so these are the strategies that we can use to make an early diagnosis before they become symptomatic. So, of course, we do routine pre-discharge newborn physical examination, but as you recall, many of them do have a normal newborn physical examination even at the point of discharge. Another method is by ordering an echocardiography for high-risk group. But again, it's not easy to identify a high-risk group, and many of them, in fact, do not have identifiable risk factors. Okay. Also, many hospitals do not even have a resident echocardiographer or cardiologist. That leads us to the third strategy, which is performing a pulse oximeter screening for all newborn, and this is what we have done since, I think, the early 2010s. Okay, this traces back to as early as 1995, and is being when it was first proposed to be a screening test for congenital heart disease. Screening test implies that there's always false positive and false negative results, but overall, if you look at the sensitivity and specificity of pulse oximeter in screening for congenital heart disease is rather specific, but it's not that sensitive. It's only about 76%. Okay, and the false positive rate is actually less than 1%. Okay, meaning if you get a positive results, that when it turns out to be not a congenital heart disease, so it's only about 0.1%. Yeah. So this is a pulse oximeter. As you can see again, this is something that can be quite easily deployed. We can easily measure the pulse oximeter of a baby before we send them home. Okay, and abnormal results are usually quite specific. Now, can we rely on other more traditional ways like heart murmur? The answer is obviously no. As you can see again, sensitivity is even lower, right? And the positive predicted value is only about half the time. So you will miss half the congenital heart disease, especially the critical ones. This slide basically shows the one of the example of protocol of doing a pulse oximeter. I will leave it to your own reading. And the next slide basically shows what needs to be done for a positive patients. Again, I will leave it to your own reading. Lastly, if we can't make an early diagnosis before they become symptomatic, then unfortunately, after they develop symptoms, many of them tend to be quite ill. Okay, then we still have to make a diagnosis, and that because the management of a critical congenital heart disease obviously is quite different from other differential diagnoses such as sepsis or lung diseases. So what are the cues or clues of a congenital heart disease? So number one is many of them, they may appear to be diagnosed with a saturation, say, between 60 to 70, but they still appear to be relatively comfortable, so to speak, okay, without obvious respiratory distress. This is especially true for ductal-dependent pulmonary circulation. Okay. Secondly, in a baby presenting with shock, poor perfusion, if they are not responsive to the regular resuscitation, also do think about duct-dependent systemic circulation. And thirdly, if a baby presented very early with respiratory distress, of course, lung parenchyma disease is still the most common diagnosis, such as, for example, pneumonia or highly membrane disease, but do consider obstructive TAPVD, as we mentioned earlier. The distribution of cyanosis is also important. In cyanotic heart disease, typically the cyanosis would be quite generalized, but if you have a differential diagnosis, such is shown in the case whereby the right upper limb and the right side of the chest appear to be more pink than the rest, then do think about persistent pulmonary hypertension of newborn, or PPHN. Okay, so do not cause respiratory distress during neonatal period, and so called the term, and therefore the term blue but comfortable. Not all of them will present this way. Important to know. Of course, these are the exceptions. Obstructive TAPVD, I'm normally just giving a few examples: tetralogy of Fallot, or duct-dependent systemic circulation. These are some of the investigations that could be useful in helping us to make an early diagnosis, and not an early diagnosis, but rather to suspect a congenital heart disease, especially after they become symptomatic. Okay, so you have a cardiomegaly with pulmonary plethora, for example, then it could be a congenital heart disease. And on the right hand side, you have a boot-shaped heart with oligemic lung field. I'm sure you will think about tetralogy of Fallot at this point. So what can we do if once we have diagnosed a child with critical congenital heart disease? The general principles is still the same as with any other neonatal resuscitation. So we maintain the A, B, and C, airway, breathing, and circulation. If the baby has signs of shock, then we provide fluids and also inotropic support. We correct the electrolyte imbalances and also glucose, and many of them we would also need to cover with antibiotics empirically. I think you have come across this particular medication, prostaglandin E1, several times in the earlier slide. So the function of prostaglandin to be given intravenously and intravenous infusion is to maintain or reopen a closed ductus arteriosus. Okay, as you recall, many of those critical congenital heart disease, the ductal-dependent systemic, pulmonary, or the parallel circulation, they all are reliant on a patency of ductus arteriosus, and therefore this medication often would need to be started if one suspect a critical congenital heart disease. So, but of course, some will not respond to it. Number one, I think as we mentioned, obstructive TAPV, this is one of those very different critical heart disease. A TGA with intact septum, if they do not have any septum whatsoever, merely by opening up the septal defect, so merely by opening up the ductus arteriosus may not be sufficient to allow the exchange of blood in the two parallel circulation. And therefore, we need an emergency procedure called balloon atrial septostomy. Okay, so this animation basically shows how it's being done. A catheter is inserted from the inferior vena cava, passing by the patent foramen ovale, and we use a balloon to basically literally make a hole in the interatrial septum, and therefore there will be more mixing of blood between the atrium. Right, this is the last slide of today's lecture. So take-home messages, not massages, messages. Okay, so always consider congenital heart disease as one of the possibility, especially with those clues that I've mentioned earlier. Many of them do mimic other conditions, and there may be so-called well in the first few days of life, and do not rely on heart murmur alone to diagnose a heart disease. And lastly, remember to perform pulse oximetry screening on all newborns before discharge. Thank you for your attention. Again, Credit to Dr. Martin Wong, consultant pediatric cardiologist from Hospital Umum Sarawak, for the slide. Thank you.